Good evening, everyone out there in Facebook land. My name is Brian Coppell. I'm a professor of neurosurgery at Mount Sinai Health System in New York City.
Hi, everyone. My name is Fiona Gupta. I am a neurologist and a movement disorder specialist and at Mount Sinai in New York City as well.
Having a movement disorder is, a very, very complicated thing, and the best way that you can arm yourself and make yourself as healthy as possible is give yourself the best information. And along these lines, we're hoping tonight will be the first in the series of information sessions where you can, in an interactive way, ask us questions about movement disorders and how we can help you and your family.
And we want to keep this very interactive and engaging. So any thought that pops into your mind, any question you have, please feel free to send it through to us. We want this to be very interactive so that we can all collaborate together.
So one of the ways that we can at least start is by fielding questions from out in the Facebook ether. Otherwise than that, we can talk a little bit about some topics that may be of interest to those who are out there.
So as a movement disorder specialist, I tell all of my patients, number one, you are not alone and you can live very well with Parkinson's in some regards if lifestyle measures and medication and other approaches are all accounted for. And I think this is really where we believe in being a team and approaching our patients with a multidisciplinary team approach. And so our hope tonight too is to give you some tips on how to live well with Parkinson's disease.
So, one of the things that I think is a big challenge for patients is understanding where deep brain stimulation fits into their continuum of care. Deep brain stimulation is a procedure in which a pacemaker is inserted into the brain in order to control the electrical signals that are behind Parkinson's disease symptoms.
Absolutely, and deep brain stimulation is one area that we really focus on, and I couldn't do it without my team, including Dr. Brian Coppell, who is our neurosurgeon, and we have a whole other team who really, help us with neuromodulation and deep brain stimulation. As a movement disorder neurologist, one of my roles is to help identify candidates and help make a diagnosis of Parkinson's disease and then take them through a course, which may include deep brain stimulation or not. And then in the deep brain stimulation world, it's to manage that, including things like programming and medication adjustments, which we can definitely get to on a more comprehensive level. I think one of the things to realize is that there's about 1 million patients in the US right now that have Parkinson's disease, but that number is actually going to double in the next decade. And by the year 2050, that number may even triple. So again, you are not alone. And we all know someone now in our lives with Parkinson's disease. This is not going anywhere. And imagine that just increasing. And there's a lot of reasons for why, the numbers are going up. I think patients are being diagnosed earlier. And then there's better treatment options, including deep brain stimulation, to allow patients to really kind of have a more fulfilled quality of life in living with Parkinson's disease. And we also know more in terms of things like environmental factors and genetic factors that may be accounting for the increased incidence. So as a whole, this is something that we really believe in terms of educating and outreach and really, kind of a boots on the ground approach to just, educating as many people as we can, whether it's our colleagues or clinicians or patients. So again, thank you for coming and spending your evening with us for this hour.
Fiona, when patients are first diagnosed with a movement disorder, what is probably their number one question to you from the the very first start? What is really on their mind as you see it?
Oh, absolutely. So that's a great question, and I think as a whole, we all want to have that crystal ball, and it's sort of well, what does this mean, and where will I end up, and what am I going to be like in 5 years or 10 years or even 1 year down the road? And I say, while we don't have that crystal ball in front of us, I believe in many modifiable lifestyle factors that you can do to, again, have your best overall outcome. And those are things like, exercise, which again is really the only thing we know that slows the progression in my mind and is very disease modifying against Parkinson's. So we could talk for hours about the role of exercise in Parkinson's disease. It's also about things like stress management, sleeping well, following the right diet, and again, finding that team. And one thing that I love about our approach at Mount Sinai is really that multidisciplinary team. And I feel like every patient should be their own advocate, but they also need to have good advocates around them. And that's really where your medical team lies.
I think over the last 2 weeks, I read a study that just came out of Europe that indicated that in fact, patients with Parkinson's disease that don't develop the dementia of Parkinson's disease have an absolutely normal lifestyle and a normal lifespan. And so it's really, really important to utilize strategies that make sure that you're going to live well. You're not just a patient with Parkinson's disease. You're a human being with a very capable body, and there are things that you can do to make that body as healthy as possible and allow you to do the things that can optimize your health in order for you to maximize the quality of your life.
Absolutely. So that's such a great point you make, Brian. And I think as a whole, my patients who know me and know me well know that I'm a bit of a drill sergeant in a way. And I really make sure that, things that you can do to optimize your life, whether it is not just physical exercise, but we talked about the dementia study, and things like mental exercise, cognitive approaches. Socializing is one of the best things we want our patients to do. You make new kind of neural connections in the brain, and it's just great for overall cognitive and physical health, and then again, follow other lifestyle measures. So I think, our approach definitely is that we don't jump right to medication necessarily or right to surgery. We know that it's a multifaceted approach that includes things like, finding the right lifestyle measures and having that team around you.
I think, it's interesting when patients come into the office for me, I'm actually struck at how little counseling they have already received about things like diet and what type of exercise. I always ask them, well, what type of exercise do they do? And they, maybe they say that they walk or they run on a treadmill. And, in of itself, some aerobic exercise is not a bad thing per se. But one of the challenges, especially in patients with a movement disorder, is maintaining lean body mass, and exercise such as resistance training and things of that nature are really critical to maintaining an optimal health, especially in the context of movement disorders. I think that patients are often surprised, when I tell them, hey, you should be, lifting weights. Sure. That they're like, wow, I was never told I could do that. They almost are kind of told that they're so infirm that they can't do these normal types of exercise, and that's a real mistake.
Absolutely. Well, so, that's the basic fundamental. Whether you've had Parkinson's for 6 weeks, 6 months, 6 years, or 26 years, and beyond, exercise is so pivotal. I've had patients come to me and say, well, how can I exercise? I can't exercise. Either I don't have the mobility or I've never exercised. In my mind, everyone can do something. And so exactly what you said, I have an approach of, some cardio, gait and balance training, resistance training, and even stretching can make a big, big difference. And again, I like to recommend that 30 minutes 5 times a week as a minimum. And then again, any more on that is really a big bonus, but it does play a huge role with overall disease modification, no matter what stage. And I think we're very fortunate to be in a community and in the country where we have access to some really great physical therapists and exercise physiologists and things like that. So if a patient is not sure where to start, we can definitely guide them. And then definitely in the last couple of years, since I've been practicing, for over a decade, there is a slew of new community classes, whether it's Delay the Disease or Big and Loud or the LSVT speech training. So in my mind, it's all good. And I think, exercise really does play a role.
So, there does get to be a point, though, where patients' symptoms around their movement disorders or Parkinson's disease or dystonia or essential tremor interferes with their ability to exercise, unfortunately. Patients can develop a tremor that is resistant to all medication. It's really hard to lift weights if you're tremoring. Sometimes they develop things like dyskinesias, again, making exercise difficult. Fluctuations where patients begin to go through a up and down period of being on medications and off medication throughout their day. And that's when we consider doing something like deep brain stimulation. Deep brain stimulation can essentially ameliorate these type of symptoms and side effects of the disease and the treatment, and allow you to resume a more normal lifestyle, resume the disease-modifying things like eating well and exercise that become problematic when the disease becomes complicated. So, you know, when you're beginning to develop aspects of your disease where it is beginning to interfere in that normal lifestyle, that's when we do, in fact, start to consider doing deep brain stimulation. Now, there's a whole host of information that a patient has to understand to get the best results with deep brain stimulation. Fiona talks about that multidisciplinary approach, and that's the approach that we take in our practice. But it's not as simple as just getting the surgery and then your life changes. You have to be the right candidate. The surgery has to be done properly. It has to be programmed properly. And these are all involving a lot of multidisciplinary expertise. One person out there in the Facebook ether is writing a question: had DBS 4 years ago, still programming, now can hardly walk. Why am I going backwards? Unfortunately, this is a question that I do get from time to time from patients that have been implanted at other centers and come see us for a second opinion. There can be a whole host of reasons for that, from not being the right candidate in the first place, to not having the electrodes placed in the optimal area, to not having the right programming and medication adjustments afterwards. So there's a whole host of reasons why somebody might not do as well as they expected before the surgery was done. Of course, it's really important to understand DBS, and there isn't any other surgical cure for Parkinson's disease. It's a symptom management. But remember, if we can control your symptoms and you can engage in disease-modifying lifestyle changes, eating well, exercise, that's a whole other area, you can optimize your health, optimize where your Parkinson's and other movement disorders go.
Yeah, and I think that's a really excellent point. So going back to your first point about, you know, when the symptoms become so troublesome, whether it is tremor or dyskinesia or dystonia or even these whole slew of non-motor symptoms like apathy and so on, they start to limit exercise. And we know it's not easy, and we know it's hard to maintain lifestyle measures, but that's where we're big proponents of acting now. So number one, you need to bring these symptoms up with your clinician. You need to have a really good open relationship. That's really two ways, is my belief, in terms of your quality of life and what's impacting you. And now we know that therapies like DBS or other medication therapies that we may have are not necessarily last line. Let's promote our best quality of life now and pick a therapy that is best for you, you know, now, and not waiting, you know, down the road. And you know, I appreciate that the comment about that we do have that had come into us about having DBS 4 years ago, having programming, but can hardly walk. So I think that is important to kind of assess, as Brian mentioned, candidacy versus lead placement. But again, sometimes I just start from scratch with programming, you know, kind of just do a washout, and we start over again, and we kind of figure out the right direction. And this is also where then we bring in our, you know, our team with, you know, other specialists and our gait and balance, you know, rehab patient people and so on. So I think as a whole, never give up is my philosophy, especially when it comes to programming and finding the right balance post-DBS.
Andrew asks, what is the average expected timeline from making the decision to have DBS surgery to the actual implant? Well, that's a good question. It depends on obviously when DBS is even introduced to a patient, and unfortunately for a lot of patients with movement disorders, they find out about the concept of DBS very, very late in their disease, where they could have achieved a much better quality of life much earlier on. So the first step is getting the information that DBS exists in the first place. But then once a patient makes the actual decision to have surgery, it generally takes somewhere between 3 and 6 months before the surgery is completed. So think about it in that time frame.
Remember, the best outcome post DBS is if you are a good candidate going in. So I think any center that that really cultivates DBS and really it does a lot of these are centers that make sure that we are sending only good candidates in. So that's kind of part of the process. There's some testing that needs to be done, including a testing where patients come off meds, and then we balance out how they are on meds. Neuropsychological testing, which is a requisite for every patient, no matter what, and then just a good kind of comprehensive evaluation to make sure patients are a good candidate, and we will never put a bad candidate forward. And that's, again, I think the best outcome measures is if you're a good candidate going in. So this should not be a rush decision by any means.
Now we're here live, so please don't be shy. Ask us whatever question. If there are all sorts of aspects to movement disorders that we're happy to tackle here. We don't have to talk about deep brain stimulation only. There's all sorts of things about lifestyle that we've talked about, exercise, diet, whatever you want to talk about, we can make this yours. Got a question. What is the workup for DBS like? Okay, well, when the time comes that people are interested for deep brain stimulation, they typically engage with a neuromodulation center, such as what we have at Mount Sinai, and they'll come in and have a initial consult with Dr. Gupta, who will assess their movement disorder, what their historical treatment has been, maybe go over their medications to make sure that surgery is even appropriate in the first place. Some of the best news that we can deliver to patients is that they don't need surgery right then and there, and that they just needed a simple medication adjustment that can improve their quality of life.
Yeah.
But should we determine that surgery is appropriate, that DBS is inappropriate, patients will typically undergo a series of behavioral tests related to Parkinson's disease or other movement disorders. In the case of Parkinson's disease, you'll come in for something known as an on-off test, where for 12 hours you'll be off your meds completely. So we get a real sense of how your disease looks like in the purely unmedicated state. We then give you a medication challenge in the office so that we can carefully quantify exactly what the medication's doing for you. And that gives us an idea not only of how good of a candidate you are, but it can give us clues about what type of target to use to treat your disease in a personal way, to treat your Parkinson's. Everybody's Parkinson's is a little different. And we try to tailor our treatments to a patient-specific Parkinson's disease. Patients also undergo a neuropsychological evaluation because, again, Parkinson's is not just a moving disease, it's a thinking disease. There are emotional components to this, and we want to treat the whole person. And it's really important for us to get this part of the evaluation in order to sort of get a global sense of what the Parkinson's and other movement disorders is doing to you. Then finally, patients will undergo a very special MRI that maps their brain to allow us the best images and targeting to do the surgical approach. Very often what we'll do is we present patients in our multidisciplinary conference that we have once a month, where not only do you have one movement disorder doctor, but you have a whole host of movement disorder doctors. Sometimes 15, 20 people in a room looking at your case, so that we literally get the best of many minds together. And so once this whole process is done, then patients typically go to surgery. Sure,
that collaborative approach is really key. And I want to touch on something you said, Brian, which is really tailoring patients' therapies. One thing to realize is that there are no two people alike with Parkinson's. There are no two people alike in my practice. I think in New York City, in the state, even worldwide, in terms of having the same type of Parkinson's, and therefore there's no algorithm. So there's no template that tells me start this medication and go to this medication and so on. So it really is a very individualized, tailored approach. And I think this is really where a movement disorder specialist is really, really key in terms of being able to take a comprehensive history, listen, do a very detailed physical examination, and really go into all of the caveats of Parkinson's. Again, this is so much more than a motion or movement disorder. This is so much more beyond, are you tremoring, or are you stiff, or are you slower? And this is really where I think there's a lot of kind of lack of insight into what we call these non-motor symptoms of Parkinson's disease. And I want to just take a minute to touch on those, because it's very interesting that how many clinicians are not even aware of non-motor symptoms, but also patients. And these can be things like, and we can name hundreds of these symptoms, but some of the key ones are things like apathy. So apathy is kind of the lack of motivation. Some patients can have some anxiety, particularly when their meds wear off, that can occur. And even sort of just frank, kind of just depression and not feeling like themselves. The one thing I always tell my patients, but also their caregivers and their spouses and their loved ones, is this is not necessarily the patient. This is very much because of these differences in the transmitters in our brain, like dopamine or serotonin. These are the chemicals that make us feel good in our brain. These are very deficient in Parkinson's. So I think the first step is realizing that some of the mood disorders are not necessarily your fault or your loved one's fault, and really working, with the team to try to overcome that. Some of the other non-motor symptoms that we could talk about, and one of them that I really, really hammer home, are things like sleep. So sleep is so disrupted in Parkinson's disease, and oftentimes, I tell my patients, until I fix your night, I'm not going to really be able to do a whole lot with your day. Most patients with Parkinson's can fall asleep okay. They're just up every couple hours and then up again. That's called sleep fragmentation. Another thing is REM behavioral disorder. This is when patients may have vivid dreams or yell or act out in their dreams. And again, that confers a very poor quality of sleep. So I think, it's important to have a lot of awareness into not just the motor disorders, but the non-motor disorders. And again, we could have a whole nother session on this. Other things are constipation, urinary issues, fatigue is the big one, the taste and smell issues, and so on. And so again, non-motor symptoms, are really important to identify and then bring up with your specialist, because they are very treatable kind of in their own right.
Okay, remember, this is a live event, so don't be shy. Ask us some questions. Go ahead, type it in that little box down there. We can, whatever you want to ask us, go for it. We're here at your beck and call. One question that has just come by is somebody asking about what is focused ultrasound. I hear about this often in the same context as deep brain stimulation. So long before we actually had deep brain stimulation, which, as I explained to you, it's like a pacemaker for the brain, where an electrode goes into a certain target of the brain. We regulate the electrical symptoms or signals underlying the symptoms of movement disorders with this electrode. We used to actually burn tiny holes in the brain that actually did something very similar. We did this with a type of energy called radio frequency, which is kind of the energy in your microwave. Recently, a device called focused ultrasound has come on the scene, which utilizes beams of ultrasound or sound energy in an MRI in order to essentially treat some of the symptoms of movement disorders such as Parkinson's disease and tremor and things of that nature. Currently, it's really important to understand the only good data that we have out there for focused ultrasound is to treat tremor, not the other symptoms of Parkinson's disease, although that is in fact being discussed right now. One of the things that I think patients are told about focused ultrasound that is a little bit of a misnomer is that it's non-invasive, and that is true from a certain perspective. Certainly there's no incision that needs to be made. Patients are completely asleep, But make no mistake, a hole is being burned in the brain that is irreversible. And so it can be very effective for certain symptoms, but in my opinion, it has a certain degree of disadvantage in that it can't be programmed. If the lesion is in the wrong place, which sometimes can happen with surgery, you can't move a lesion. There's no way to do it. An electrode that is slightly not in the right place can be moved. It's a big advantage of that. And you can actually sculpt the electrical field postoperatively and actually provide stimulation according to a patient's needs. The lesion itself is kind of static. Now, of course, a lesion is really nice in the sense that you don't have hardware long-term inside your body. But again, it is a lesion. It is something that is permanent in your brain. So I just want to at least make sure people understand that this concept of it being non-invasive is really not exactly true.
That's a great point.
Another question. What patients with essential tremor are candidates and when to consider? Okay, we've talked a little bit about Parkinson's disease. Tremor is actually perhaps the movement disorder symptom that is exquisitely sensitive to deep brain stimulation. Up to 80% of the average patient gets at least an 80% reduction in their tremor, which is really, really life-changing. And in essence, there are really two groups of patients, at least in my experience, and you probably obviously see a lot more non-surgical candidates than I do. But essentially, you know, essential tremor is a really, really common movement disorder.
Actually, it's probably our most common.
Right.
Yeah.
But most people's tremor are very, very slight. It's a very slight tremor. Sometimes just taking a glass of scotch makes the tremor go completely away, or a glass of wine. When patients do seek treatment, usually the mainstay of the treatment is either a beta blocker, which is a type of drug that we use typically for blood pressure management, or phenobarbital, which is another type of medication.
Yes, or primidone.
Primidone, right? And so that's another name for it. And often, many patients, they take that, they do perfectly fine, they never need surgery. But I would say that there's another group where these meds essentially
don't work, or they stop working, or there can be side effects, right?
Right, and in those patients, surgery can not only reduce their tremor to the point where it's not bothersome throughout their lives anymore, but you can then basically throw your medication out because you don't need your meds anymore.
Oh, absolutely. And it's kind of interesting because, you know, essential tremor is actually far more common, like you mentioned, than Parkinson's disease. It's probably our most common movement disorder. You may have heard of it designated benign essential tremor, but actually that designation got removed in terms of the benign component, because I have many patients with essential tremor who are really debilitated, who have issues with working. I mean, it can cause issues with writing. It's a tremor of action. Some patients don't want to go to the restaurant or eat because of the severity of the tremor. And this is really where, you know, one of my favorite types of patients to do DBS on is essential tremor, because it just works really well. You know, the programming kind of sinks in, and, you know, patients can really get their lives back. So again, essential tremor is treatable, particularly with DBS. I personally find the beta blockers or the primidone to be a little suboptimal. You know, I never go in prescribing and saying, yeah, you know, this is going to really kind of block out the tremor. There's always a bit of refractory tremor. So I think, you know, that world of essential tremor with DBS is really continuing to grow, and patients are very largely satisfied.
So how should I start learning about DBS if my neurologist or primary care doctor hasn't recommended it? Does that mean I'm not a candidate? Well, that all depends. I would say the best way to deal with that situation is to educate yourself about what DBS can, what it cannot do for your particular movement disorder, and then ask very specific questions as to why your doctor doesn't feel it's an appropriate thing for you. Very often, doctors have a exaggerated sense of what the risks are. They are not particularly experienced with the quality of life improvements that DBS offers. And so as a result, in their mind, they think, oh, it's brain surgery. Why would you want to do that? And when they don't realize how much quality of life is left on the table, so to speak, when patients delay surgery for many years, you know, it's a real shame. I would say, at least in my experience, the most common thing that patients say after the DBS surgery is, I waited too long.
Oh, I hear it all the time.
Yeah,
Absolutely.
and that's really frustrating to hear from my perspective, because it means that people were suffering needlessly for too long.
Yeah, and I think this is where our philosophies align. We both have been doing this for over a decade in terms of being practicing physicians. I mean, the reason I probably went into movement disorders was just really the power of DBS and seeing what it can do, but also that we have so many emerging treatments for Parkinson's. And so just because, you know, maybe your neurologist hasn't recommended it or you're not sure about it, I think the most important thing to do is stay educated. You know, the face of Parkinson's is changing tremendously. We have so many new therapies in the pipeline. There are trials, there are, you know, just it's really kind of a plush field where there's a lot going on. So, you know, doing things like this is definitely our passion, really, that outreach and just trying to get patients on the right track. When we first started doing this, I mean, DBS was kind of considered the very last line therapy, right? Patients weren't being referred until their clinician felt that there was no more they can do. Now we've seen that pendulum swing, and, you know, and rightfully so. So really, DBS should be considered when either quality of life starts to, you know, fluctuate, or patients really begin to develop that earlier moderate stage of either motor fluctuations or severe tremors. So definitely not last line. And I think, again, staying educated through, you know, community events or events like this is really the best way to go.
How long? One question out there, Beth Conway asks, how long is DBS expected to last? Well, the good news is the answer is indefinitely. DBS as a therapy works as long as it's inside of you. It depends on what condition we are treating. So for something like essential tremor, it lasts a lifetime. Patients with dystonia that get this done and have tremendous results, it lasts a lifetime. Even in Parkinson's disease, it lasts a lifetime, but the difference between Parkinson's disease and some of these other diseases is that Parkinson's is what we call a degenerative illness, where the baseline symptomatology changes over time, unfortunately, sometimes or often for the worse. And so perhaps overall patients functioning over the course of 10, 15 years gets slightly worse over time, the DBS still continues to work. Now, remember what I said earlier, if we can control your aspects of Parkinson's disease that have been problematic in terms of you maintaining a good exercise, sleep, and food lifestyle, then DBS can help extend that sweet period where the disease doesn't interfere with the things that you do and love, basically. And that's an important aspect to think about what DBS can do for a patient with a neurodegenerative disorder.
Absolutely. I couldn't agree more. There is definitely an importance of acting now. And my mantra is, when I get asked that question every day, really, how long does it last? And I like to say, so far, so good. You know, DBS is not a new therapy. It's been done for decades. And really, you know, from especially a motor standpoint, I mean, patients that I have who've had, you know, some of the earliest implants are still doing much better from a motor standpoint than, you know, they were prior to. So again, I think, you need that team, you need that sort of support, and you know, and definitely the programming has to be spot on as well as the meds. But again, it's kind of so far so good.
One patient out there says, Tammy says, my tremors are horrible. You know, I really hate seeing that. It really is very, very frustrating. Because I know that relief is out there, and a patient to have that kind of tremor in their life and having to deal with that on a daily basis is just really heartbreaking. But, you know, again, what I'm hoping that we are trying to convey to you is that there are all sorts of hope for you in terms of the options that we can provide and our field can provide to deal with this debilitating symptom.
Yeah, and even Tammy, I'm sorry to hear that, but from also a pharmacological standpoint, I do have patients who have some breakthrough tremors that may have DBS or may have not, or have not had it yet. But there are some, definite medication treatments like anticholinergics or certain forms of, dopamine preparation that can be used, or some as-needed medications, that can be used if, tremors act up during social situations or public speaking or things like that. So as a whole, I think, try to find the best help, because it exists, whether it's, pharmacological or surgical.
Glenda asks, do you ever stop needing adjustments? Well, the answer to that is it depends on the disease state. Some aspects of movement disorders need more adjustments than others. A well-placed lead generally doesn't have to be adjusted more than a few times a year. If you're coming in chronically, on a every 2 weeks or a monthly basis, we do have to start to wonder whether the leads are in the optimal position, and we can assess that. But think of the DBS itself as like a digital drug, and that sometimes medications need to be adjusted to optimally treat you. The stimulation also sometimes has to be adjusted.
It's nice to see you on, Glenda. Thanks for joining.
One question has come up is, how does DBS work? That's a really great question, and it's a very complicated question. But as I alluded to earlier, the brain itself is an electrical organ. All of the things that a brain does essentially is served by an electrical signal, much in the same way that the heart works essentially by electricity. Sometimes these electrical signals, for whatever reason, become abnormal. In the situation of Parkinson's disease, a certain group of cells in the substantia nigra die. It stops making a chemical called dopamine, and this lack of dopamine sets up a abnormal pattern of electricity throughout the brain. By placing an electrode in certain strategic areas of the brain, we can overcome this bad electrical signal, normalize it to some degree, and allow the symptoms to be treated accordingly.
Right, it's all kind of a complex circuit. And that's a good point that you bring about sort of this dopamine degeneration. What's really interesting is that we know by the time someone's actually diagnosed with Parkinson's disease, whether they have a tremor that emerged, or they have some gait issues, or feeling slow or stiff, there's maybe a 50 to 70% kind of reduction in dopamine cells already in the brain. And so, I'm a big believer in trying to act early, in terms of, trying to identify sometimes premotor symptoms of Parkinson's disease. These can be things like anxiety, depression, loss of smell, constipation. One of the big ones is that REM behavioral disorder I talked about, which is the yelling and talking in your sleep and so on. So that's kind of a premotor constellation where you have these kind of slowly degenerating dopaminergic neurons. So remember, when someone actually is diagnosed, there's almost 50 to 70% dopamine reduction. And again, why it's so important to act now. Gone are the days where someone would come in and, they would have a little bit of a tremor, and the clinician would say, well, come back in a year, it may or may not be this. We know that the earlier you act and you diagnose and you get the lifestyle measures on board, which includes the sleep and the diet and the exercise and the cognitive and the socialization, you're going to do better. And this is really where finding the right pathway for you, has to be assessed at each and every visit.
Lynn Polizzi asks, if a patient has a history of inflammatory changes in their brain, can they still do DBS? Well, Lynn, I would say that it depends on what the source of these inflammatory changes. If there is an ongoing acute inflammatory process, I would certainly like to understand that a little bit better and optimally remove it before going forward with deep brain stimulation. Certainly any infectious issues have to be addressed long before an implant is placed, but it really depends on the nature of this inflammatory changes. In our center, because we are so experienced, We have operated on many patients with other comorbidities and medical conditions, and we are very successful. So it really just depends on what the specifics are. So, and again, the best way to get a better sense of specifically for yourself is to come in and have an evaluation so that we can really dive down deeply into your specific situation.
Oh, sure. And I think this is really where your approach of being very meticulous and reviewing every image. And, it also depends where these changes are. So DBS is not just one target. There's actually multiple targets in the brain depending on the indication. So this is really where I think the team conversation and sort of a yes go or no go is really, really important. So no, that is absolutely not a rule out. I agree.
So one question out there is, what main aspects of a program should I be looking for? I think what they're asking for is, how do I pick a center or a group of doctors to do my DBS surgery if I've made the decision? And that's a really, really important question, because, I'm sure that all of you go out into the internet, you go on forums, and you see a whole host of results, anywhere from my life has changed miraculously, my life has changed, to patients that are like, I'm not doing very well. And so I think often the critical difference there is where they had their surgery. Very important is ask your surgeon whether he or she, how many times they've done the surgery is really important. How many times a week do they do the surgery? How many times a month do they do the surgery? Really important, I would say, is that they go to a center where they're doing DBS at least once a week, I think that if you're doing it less than once a week, you're not quite as adept at it than other centers. But I would say that as a rule of thumb, I would like to have them do this on a weekly basis, and have done several hundred of these cases to get the best results. I think having a center that has many movement disorder neurologists that have expertise in deep brain stimulation is also really important. If you go to a center where there's only one doctor and that person goes on vacation, and you have a coverage that may not be familiar with your deep brain stimulation, that's not an ideal situation. So you want to go to a center where there's a breadth of expertise and a depth of expertise. So these are things. What would you say?
I agree. And again, when picking the right team for you, whether it's DBS or not DBS, if you have a movement disorder, you need a team. You need people to be your advocates. So I always say, we're in an area in New York where we have a lot of specialists. And I always tell my patients we're very lucky to have that. But go to a team that you feel comfortable with. You should have open lines of communication. Your visit should be new every time in terms of the specialist should be looking at you with a fresh set of eyes every time, and not just sort of a glossed over visit. There are so many factors that go into living well with Parkinson's disease, and taking charge of your visits and really having that team around you with communication is so vital, believe me. You should always feel like you're being listened to. You should come out of every visit with a plan. So whether, a patient has had Parkinson's in mind for 6 months or a year, up to 34 years, we always formulate a plan in terms of what is our next step, and then what's our plan B, C, and D after. Because, you want to really have, an encompassing level of care. And, we're fortunate with Parkinson's to be able to have, services and therapies and so on to really be able to offer that to patients. So I think go where you're comfortable.
Quincy asked a really, really tough question. How often do you witness a patient regret, having the surgery? Okay. So Quincy, like I said, I've been doing this now 14, 15 years. And, obviously when you've done it that long, you can see a spectrum of patient responses. As I said earlier, by far the most common thing that patients say to me is that they waited too long. And I want you to also consider the following, that no patient has ever asked me to remove their device once I've implanted it. So for whatever that is worth. I do think that expectation about what DBS can do for you can change how a patient feels about the surgery afterwards. And sometimes patients can maybe feel that they have or that DBS is a curative, or that they have unrealistic expectations. And in that situation, patients may feel disappointed, which obviously disappoints me because I'm here to serve, and I kind of want people to be happy and have a great quality of life. But again, the fact is that patients haven't asked me to remove it. So I think that says something about the concept of regret.
Right, and I think, again, making sure that patients are a good candidate going in. I mean, we're very lucky to have such a precision in terms of your skills with, getting the lead in the right place, and then really kind of having that team after with the programming and the meds. I don't think I've ever had a patient that I regretted, but I think who had regretted it. Yeah. So Lynn asks, how reliable are DAT scans? I had a positive one 2 years ago, and now I've had a negative one. So nothing surpasses a good clinical examination and a clinical history and physical examination. The DAT scan can be a useful tool. It's basically a functional imaging scan, almost like a bone scan, where an isotope is injected, and we're looking to see how the brain takes it up. But nothing is 100%. If anything, I think there's like a 96, 97% specificity. So, nothing surpasses a good history and examination. And there are many things that may interfere with a DAT scan. Things like medications that patients on, the timing of the scan, when it was done, and kind of where they are in their clinical course. So I do not go by DAT scans. If anything, I go, by history and examination. That's really where the art of movement disorders lies. And sometimes we don't get it at the first, take. And that's really where we need to see patients, over a couple of visits to really make that diagnosis. So I would put the DAT scan aside in my mind, and I go more.
Andrea asks, what are the side effects are there? What side effects are there after having DBS? Another great question. All surgery has risks and side effects. If you ever go see a surgeon that says there are no risk or no side effects, if they guarantee you something, run away from that person. Okay, so what are the risks of DBS surgery? In general, the scariest risk is bleeding in the brain or stroke. That's the thing that everybody kind of associates with brain surgery. There's about a 1% risk of having some form of hemorrhage in the brain, and that can run a gamut of effects, anything from something that we just happen to see on a CAT scan after surgery that doesn't bother you in one bit, to having temporary side effects such as difficulty with speech or having temporary weakness. And then obviously, potentially it can be life-threatening, although that is really, really rare. Infection's another risk, and the infection ranges around about 3 to 4% of the time. And infection, again, gamut of effects. Sometimes it's just a superficial infection we can treat with antibiotics, and you go on your way and have a good quality of life. Other times we have to remove the device and kind of have to start again. Patients, even in that situation, can go on and have a really great benefit going forward. The device can break. Any man-made device can break. Like your DVD player breaks, your computer breaks. Same thing like this, there can be malfunctionings. The leads can fracture, the device itself can malfunction, and if that should happen, we have to fix it. And that happens about 3 to 4% of the time. Other symptoms that can happen with programming, you can get tingling sensations, pulling sensations. Very rarely, patients' volume of their voice can get lower, although that generally happens in the setting of having vocal problems to begin with.
Right, and stimulation effects, can be accounted for. We then know what direction to go in. So, and I think, again, going to a center that has a lot of experience,
and that's actually
less than
that's actually been shown with studies. Mike Oken in Florida demonstrated that the greater degree a center has in terms of their experience, the less likely these type of side effects to occur. So that's another reason why to pick your center well.
In the final minutes we have left, Glenda did ask a wonderful question about, can you speak to dietary measures in Parkinson's disease? One of the concepts, again, where Dr. Capel and I align quite a bit, is just a whole kind of area of focus on wellness within Parkinson's disease. And one thing we're learning a lot more is that Parkinson's is so much more than beyond the brain. It's actually a gut disorder, and there's over 70% of patients that have gastric issues, gastroparesis, poor absorption. That's when patients may take their pill of levodopa, and it just never doesn't kick in, or it takes 90 minutes to kick in, or and that really is because of poor GI absorption. One thing I do recommend for dietary factors is smaller, more frequent meals. So patients with Parkinson's often have trouble digesting one big meal at once, and they can feel very bloated, or again, it can interact with their medications and so on. And so as a whole, I think smaller, more frequent meals definitely keep your nutrition up. We believe very much in brain healthy foods, foods that are really kind of full of antioxidants and have, the colorful fruits and vegetables. Foods that have vitamin E are super important, and we can do a whole nother sort of Facebook Live on just supplementation within Parkinson's disease. And one thing I think we're all guilty of, all of us, is not drinking enough water. So hydration is absolutely crucial for Parkinson's disease for many different reasons, to help with the GI motility in the gut and any constipation issues, to help keep up blood pressure, and just for overall well-being. So again, diet is important. This is something that, again, plays a role in how you're feeling, and I think hydration is absolutely crucial. So thank you for that question.
Kevin Wilson asks, what are your thoughts on inpatient and or outpatient rehab after DBS? Good, another really, really good question. I conceive of DBS as sort of the beginning of your treatment in a lot of ways, and that once the DBS can alleviate some of these noxious barriers to living a good lifestyle, the rehab portion of that with exercise and intensive rehab can only make the results even better. With regards to inpatient or outpatient rehab, I think good rehab is important. I like outpatient rehab better myself, just because, the goal of when I operate on patients is to get them to live as normal of a lifestyle as possible. And normal means being home. And so, from that standpoint, if outpatient can be rigorous enough and address some of the issues that we've talked about earlier, that would be my personal,
absolutely. And there have been some sort of pilot studies looking at sort of inpatient DBS post-programming while patients are having rehab, which is pretty intensive. But, the outcomes really, in my mind, are we want a patient just to get back to their overall functionality and just really maintain a quality of life. So I think rehab is super important. I probably prefer a good outpatient approach. One thing I do with, my patients is I communicate with their therapists, the OTs and the PTs and the speech therapists, and we're always, again, they're part of the team to make sure that patients have sort of the right plan of action for them. So, get the most out of that you can out of your sessions.
David Kubredas says, and again, David, if I just mangled your name, I apologize. Patients should have a neuropsychological assessment before and after DBS. I 100% agree. We want to treat the whole person. Movement disorders, especially Parkinson's disease, isn't just a moving disease, as I said before. It's a thinking and a cognitive and an emotional disease, and we want to treat the whole person. There's only one way to do that, to measure it and to do the appropriate thing. Jason Conrad says, if a lead is implanted incorrectly, can it be corrected? The answer is yes. Very often it can be corrected. That's one of the advantages of deep brain stimulation. We can move the lead if it's slightly off target, or even if it's wildly off target, as sometimes patients come referred to me from other centers. That's why I personally feel it's actually a better therapy than focused ultrasound. You cannot move a hole in the brain. You can't fill up the brain with more brain, or a hole with more brain. It just doesn't work that way. So that's the chief advantage of deep brain stimulation. Question was, how do we make an appointment to see you guys? Well, that's so the best way to do that is to either go to the Facebook neuromodulation page for Mount Sinai, or the Mount Sinai neuromodulation website itself, and basically find the phone number on that and make the appointment there, basically.
Yeah, we'd love to see you. Lynn writes, what can you recommend for apathy? It's a huge problem. potentially low-dose ADHD meds. So apathy is really a lack of motivation, and again, in the remaining time we have, it's more just patients don't want to do things they like to do. You know, I'm a minimalist when it comes to meds. I mean, I will prescribe the right regimen of medications for patients, but I really believe in acting now and taking charge of it. Number one, realizing what apathy is. And again, it's not your fault. It's very much a chemical thing. Number two, working with your team, working with your loved ones, picking 1 or 2 activities a week that you would have done before that you may not want to do right now, and just do them. Really, you have a large wall to scale, but you can scale it. Exercise is wonderful for apathy and other non-motor components. And Lynn mentioned some low-dose medications, potentially for ADHD. I mean, again, I think in the right patient, it could be an option, but I'm more of a non-pharmacologic approach when it comes to apathy. And we have some wonderful psychologists and neuropsychiatrists who are on our team who are just terrific, and we all kind of share patients together. So again, that's a multidisciplinary approach.
Yeah, good point. So we're kind of wrap up now. And we're going to do this again really soon. You'll stay tuned to our website and to our Facebook page. We will let you know. And I really encourage you to gather your questions, gather the pieces of news that you see throughout the week, and gather that to us, and we'll answer that in real time. Again, if you want to come see us, check out our website. My name is Brian Coppell. I'm a professor of neurosurgery at the Mount Sinai Health System in New York City.
And I'm Fiona Gupta. I'm assistant professor of neurology and a movement disorder specialist, again, also at Mount Sinai. And this was just a pleasure.
All right. Have a good one, everyone.
Thank you.
Take care. Bye-bye.